Good evening, everyone, and thank you for joining our Men's Health webinar. We will start with a few housekeeping items, and then I'll introduce tonight's speakers. First, your participation in tonight's webinar is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and our speakers. If you wish to ask a question, please type it in the chat box at the lower part of your screen, and we will have a Q&A portion at the end of the presentation to address these questions. Our presentation tonight will last for approximately 1 hour and will be presented by Dr. Omer Raheem and Dr. Kocjancic of the University of Chicago. Both Dr. Raheem and Dr. Kocjancic are professors of urology at the University of Chicago and specialize in men's health, particularly in the areas of erectile dysfunction and urinary incontinence. After completing his medical degree and master's, Dr. Raheem then went on to complete both his internship and urology residency at the University of California, San Diego, followed by a fellowship at the University of Washington in Seattle, Washington. Dr. Kocjancic attended medical school and his internship at the University of Trieste in Trieste, Italy. He then completed his residency at the University of Milan in Milan, Italy, before attending a fellowship in female and reconstructive urology at the Savapirovic Foundation in Belgrade, Serbia. Thank you for joining us tonight, and now I'll turn it over to Dr. Raheem to get us started.
Thank you, Annie, for this nice introduction, and welcome everybody. Really very honored to be here tonight. I'm really joined by my friend, my partner, Dr. Kocjancic, who we will be talking later on urinary incontinence. I'll be talking for the first about 10-15 minutes on erectile dysfunction. This is under really one webinar tonight we're presenting to you, and I hope you find it educational and informative at the same time. So welcome again to the Men's Health webinar. I want to also give a shout out to Boston Scientific, Annie and her team, for putting this together and hosting it and making it a regular appearance every Tuesday night of almost every month now. So thank you, Annie.
Thank you.
So with that, I'd like to really start the program with kind of overview of understanding the erectile dysfunction, or ED. So what are the treatment options we have? But let's start with setting the stage for this. This is ED we're talking about here. ED, it's defined as a persistent inability to achieve or maintain an erection that is firm enough that cause intercourse. It's quite common. We know ED affect about 1 in 5 American men over the age of 20. Obviously, it can affect any man over their lifetime. More than half of American men over the age of 40 have some degree of erectile dysfunction, and about 39 million of American men suffering from ED right now. The way erectile function occur in our penis is that there is arousal process that causes the nerves and surrounding penis becomes activated, and that lead to a muscle relaxation, allowing for blood flow to arrive to the penile tissue here. You can see from this cross-sectional view of the penile area, the penis in a flaccid state, and then here the penis is big and engorged because of the erectile states. Why? Because the spongy tissue here called the corpora gets relaxed and dilated, so the blood vessels will bring a lot of blood, almost you're opening a floodgate into the penis to get your erection. This additional amount of blood will increase the pressure inside the corpora cavity of the penis, causing stiffness and full erection. This erection tightens the vein of the penis, and so the blood cannot escape or leave the penis, and that will maintain the erection for the duration of sex. When it comes to ED, we know that affect a lot of men, and it's not only affecting them, but also reducing their quality of life. It has a lot of negative impact, or broader negative impact, on health quality for men, particularly for men who are young and healthy. You wonder, what's the cause of ED? Is it my head? Is it due to organic cause or physical reason why I'm having ED? So we start searching about the causes. This slide kind of shows the quality of life impact here. And we know that ED can affect not only relationship with partners, but also mental health, social functioning, general appearing and health, physical health of the patient himself, It can reduce the vitality, physical functioning. It can also has a role of, affecting the mental health of the individual affected with this problem. We know the causes, and we understand that very well now because there has been a lot of research in this area. ED can be caused by a number of very known medical conditions due to, for example, a vascular problem. That's a vessel issue in about 40% of men, due to the effect of the endothelial function of the blood vessels. Could caused by diabetes. It's a big thing. As we know, obesity is another metabolic syndrome that we are facing on a regular basis, and also medication side effects, about 15%. The rest of the pie chart show you that other causes, like if patient has surgery, for example, or trauma to the pelvic area, or maybe they have a neurological damage due to a central condition affecting the nerves that reaches to the penis. As you can see, there's a host of conditions can cause this problem. And also, I want to mention the psychological effect of the some men can also has a toll on having a reduced amount of ED in those individuals. So you see, there are top three, we call it physical causes: vascular, being the blockages or narrowing of the blood vessels, and diabetes and medications. But also remember, and I'm a urologist, I see a lot of patients with who survive prostate cancer. Prostate cancer surgery or radiation can lead to ED, unfortunately, in a big chunk of patients. I want to also mention the heart conditions. If you have an underlying heart condition, or you are suffering from a cardiovascular insult happened to you years ago, that you also have at risk of developing ED. With that, also peripheral artery disease. This is the PVD. When you have blockages in the blood vessels, that goes down to the lower extremities. So you see, there's a host of conditions. Vascular is a big term, but could affect the heart or the peripheral vascularity that reaches the penis as well. I want to just pause a little bit on ED and diabetes connection, because this is a very, very common problem. According to the U.S. data in 2012, there's about 16 million American men affected with diabetes. And with diabetes, you see, you have a sequelae of diabetes. Diabetes can be affecting from the head to the toe. Any organ can be affected, and most men with ED, with diabetes can actually present with what we call a severe type of diabetes, of ED. So, for example, ED can occur about 15 years prior in men with diabetes. Diabetic men tend to have a severe form of ED, as I call it, and may not respond to medication. And also, about 1 in 2 men with diabetes have sexual trouble caused by their condition. So what that tells us that in men with diabetes, there are totally different other healthy men, because their ED could be one of the severe form that require more attention and more treatment. So if you have a diabetes and you also suffer from ED, my advice to you is to seek advice from a urologist like myself, or even seek help from your local doctor about how can we control diabetes, how you have a better glycemic control, whereby your A1C drops down to lower levels, your diabetes is better controlled, so you can feel better about yourself and ultimately improving your erectile function. Another big thing is, I mentioned the heart conditions. This is a nice a graph or slide showing the relationship between ED and also heart diseases. We know there is arteries that supply the penis. They are very small. The diameter of each penile artery is about 1 to 2 millimeters. That's almost almost half the size, or about 30% the size of the diameter of the artery that supply the head, for example. So you see that there are tiny vessels here compared with the rest of the blood vessels that surrounds the body or supply the body. For example, they supply the heart here. It's about 4 millimeter here to the carotid artery, about 7 millimeter, and then the femoral artery, which is a vessel supply the leg, for example, is a big one. It's about 8 millimeters. So you see the 2 millimeter vessels are very small, and the reason I'm saying this because this artery, the penile artery, are more prone to get blocked when men have underlying endothelial dysfunction that often associated with cardiovascular, diabetes, obesity, metabolic problems. Now, the other big thing that we also see in men with erectile dysfunction, with ED patients, is that they are often come with a prior history of cancer therapy, whether that would be pelvic surgery, radiation to the pelvis. They had the prostate removed, the bladder removed, they had their colon removed, rectal removed. This all surgery can actually disrupt the innervation to the penile area. And you can see here from the slide here, from the nice picture here, this is the bladder here, that's a urethra, and in the middle here, the prostate. So when the surgeon removes the prostate, guess what? He's going to also, touch on or maybe impair the innervation. That's the nerve that surrounds the penis that also leads to erectile dysfunction. So in summary, I think if you have a history of removal of prostate or bladder or other bigger organs in the pelvis, I think erectile dysfunction tend to be in those men more severe in nature. I mentioned briefly about surgery. So men who receive surgery or radiation, they tend to have a higher prevalence of ED in the range between 25 to 75%. Erectile dysfunction can result from surgery. This is called radical prostatectomy. And it can last for up to 1 year after surgery. Also, men can suffer from sexual erectile dysfunction after radiation therapy, up to 50%. So if you doesn't matter if you have radiation or surgery, the prevalence of ED in those individuals can be as high as 75%, which can last up to 1 year. Certainly, other conditions that can develop that need to be addressed as well is Peyronie disease. This is a condition that can cause curving and deformity and disfiguring the penile structures. Peyronie is the development of a scar tissue, or we call the fibrous tissue, that can build up on the penis that cause curving and painful erection. So the patient will oftentimes, they come with painful erection. They cannot penetrate because of the curve. They have difficulty to satisfy themselves on their partners. And then they have a lot of anxiety and stress associated with this condition. This condition also can be developing after surgery. So really the two big things that I talked so far is ED and Peyronie. But remember, there are other conditions that happen after surgery, after radiation to the prostate, if you have diabetes, other conditions that can lead to ED, which is also shortening the penis. There is also conditions that can disfigure and prevent you from having sexual function. So the important message here is to really seek help, and we're more than happy to help you with getting you fully evaluated in our clinics, and our expertise are happy to provide to you. But having said that, really, there are some good news. I mean, there are treatment options, and this is the beauty and the art of medicine is that yes, those are problems, and there are maybe difficult problems to solve, but are also equally there are good options for treatment. So, what are these options for treatment? I guess with ED, as we all know, pills, injectables, other form of therapy, oral therapy, and medical therapy are available. So, for example, if you look at specifically for the oral pills, this is a very commonly available Viagra, Cialis, Levitra, and others can actually available and be taken about 30 minutes before sex, and that will improve the blood flow to the penile area. Right? You have to be aware of the side effects, because in about 50% of men who takes medication, it may not work. And why is that? Because they may have we call it severe ED, right? You should be also aware of the side effects that could be also causing headache, facial flushing, stuffy nose, upset stomach. You might see some colored discoloration of the blue light as well. The important thing really to talk to your doctor and to speak about that, and also specifically for a patient who has taking other medication like nitrates, for example, or in alpha blockers. This is the medication for the prostate. So you need to make sure that you're not mixing the drugs so that you don't have a side effects that can be lethal. Other form of therapy, I'll come back to the vacuum pump, but I want to mention the injections as well, which is a very important aspect here in the slides. So injectional therapies are basically medicine that goes directly into the corporal space of the penis, as you see from this figure here. So you see the penis here, the needle is going into almost like a 90-degree shot to the inside of the penis. This is a Caverject or a prostacyclin medication. There are different forms of that. There's a bimix, trimix, quadmix that you get from a compounding pharmacy. The goal of these medications is to act locally. It will give you that dilation, that blood flow, that gush of blood flow locally, so you get a full erection. I have to warn you that there are some side effects as well, like penile pain, formation of some blood blisters underneath. It could be also formation of scar tissue. It can be painful sometimes, generally speaking, and this has been my experience with my patients, that patient will tell you, Doc, I'm about to have sex. How come I inject myself with a painful needle? It will take the romance, it will take the spontaneity out of the patient, which can be very, very putting, if you will, right before sex. So you just have to be aware of these side effects and overcome the problems. I'm going to go back to the slide earlier about the vacuum pump. This is a step up, if you will, from the medications. The vacuum pump are designed to create a full erection by negative pressure. It's a big device that we put it on the penis and has a rubber band to trap the penis blood inside to maintain the erections. As you know, there are side effects. We need to make sure that erections you have some degree of erections that help you the most. Sometimes patient will tell me it's cold, and it can cause some skin irritation as well and bruising. Again, you have to retime yourself well before sex to do that. One more thing about the urethral suppositories. This is a medication that goes directly to the head of the penis. This is a medication that gets deposited directly to underneath the head of the penis and get absorbed locally as well. It may cause some pain, irritation at the site where the patient injects. But again, it's a form of medical therapy, we call it, right? So you take it right before sex, and then the idea is to improve the blood flow. Moving on to something really important that you should be aware of as well as part of the medical therapy for severe ED is called penile implants. And the way it works is that there are a pair of cylinders that implanted in the penis. There's a pump inside the scrotum and a reservoir that contains blood flow. These are all connected through a tubing. And there's a mechanism whereby there is a circulation between the reservoir and the pump and the cylinder to allow you to have a full erection. It's really very effective in the ranges of over 90%. 98% of patients will report a full extension, full excellent satisfactory erections. So at 7 years post-implant, 94% are still, 94% of patients are still using these devices and free of any revision surgery. So very important stats here or data points that tell you how robust and how durable this device are. The most common side effects are pain for recovery or during recovery. Some mechanical issues can happen. Although this has been almost about millions of implants are placed around the world, and the risk of infections is less than 0.5%, risk of erosions or mechanical problems less than 1%. So you can see risk of these are very, very rare. Now, I'm going to show a really quick demonstration of this device, how it works. It takes 1 hour to do in surgery. You could go home the same day. And the way we install this is all through the penile opening. There's a pump we insert in between the testes, and you can see the model here pressing on the pump, elevating the penis through erections, mechanical erections that you can see here. Very efficient, very robust, and very friendly to use. There is some important aspect of that device. There are this is called 3 piece. There are 2 piece and there's 1 piece. Depending on your anatomy and your degree of using the device. If you have a good hand function, I think you qualify nicely for the 3 piece. I want to mention the benefit. I think benefits is important. I think the benefits, we talked about that. Benefits of the penile implant is it's more designed to be a permanent solution for ED. It's spontaneous because having sex when the mood strikes, there's no need to wait for the medication to work on you, which is a very important aspect, especially for men who are active and who are engaged with their partners. Erection can last as long as you desire. That's true. You can maintain erections, you can maintain ejaculation, you can maintain your sensation, all the same. We're not changing that for you. In fact, in any way, we are improving the rigidity and penetration for you. Entirely contained within the body, no one will know that you have it. That's very true because it's concealed, and when it heals, it's become part of your body. High patient satisfaction, which also includes partner satisfaction, over 98%, typically does not interfere with ejaculation, as I mentioned, or sensation, or orgasm. Implants have been used in more than 40 years. And so far, we have millions of these implants are implanted worldwide, particularly in the United States. Insurance coverages, I think a patient asked me whether my insurance will cover it. I will tell you that if you have Medicare, I think you have a good chance of coverage. Our team will do a good job in verifying your paperwork and make sure that you're squared away to do their implants. We're not going to give you an expected bill, and that's not the common pathway. We do our diligence to make sure there's nothing uncovered for your procedure. Lastly, I want to mention that is important that to really talk to your doctor, really important. And also, I'm going to mention this website here, EDCure. That's edcure.org. It's a wonderful website because through that, you can find a lot of resources for what we call prosthetic surgeons or prosthetic urologists like myself and Dr. Kocjancic. You can reach there and you can ask to speak with me or make an appointment to see me. With that, I'd like to turn it over to Dr. Kocjancic, and thank you so much.
Thank you, Omar. And I would like to echo Dr. Raheem in thanking Boston Scientific for organizing these events. I think we strongly believe in education provided to the patients, because an educated patient knows how to what are the options for a healthy aging, and can have a better outcome in general health advices that we can provide. We are partnering with the patients in order to improve the quality of life, and we are specifically dedicated about quality of life of aging male in this webinar. So Dr. Raheem mentioned and very nicely presented the options for erectile dysfunction. Let's talk about male stress urinary incontinence. So urinary incontinence is a phenomenon that is typical in female, with aging female, with childbirth. They start leaking urine. But in men, it's also a pretty common problem, especially after prostatic surgery. But what is the incontinence? Incontinence is an involuntary leak of urine through the urethra. This is because one or both sphincters, we have two sphincters, a striated and a smooth muscle. There are different type of muscles that one is providing a baseline continence, while the other one is providing an extra increase in resistances when, for instance, we need some more generate more pressure in the abdominal, in our belly cavity. For instance, when we cough, when we sneeze, when we lift something heavy, this is the striated muscle that actually closes more the outlet. Because of the surgery, because of removal of a prostate, there is a high risk of damaging these two systems. So let's have a better look on the understanding of the anatomy of the lower urinary tract. So starts with the bladder. The bladder goes outside, so brings the content of urine, basically, that is contained in the bladder to the urethra. And as you can see here, you have a prostate, you have sphincter. There are two sphincter mechanisms I mentioned before. As you can easily see from this diagram, whenever you remove the prostate, there is a risk for damaging the sphincter. So approximately between 9 to 16% of patients after radical prostatectomy, this means when the prostate is removed for cancer, will develop some sort of urinary incontinence. But that's not the only condition. This is the most frequent one, but there are other reasons for incontinence, like for instance, neurogenic disease, prostate surgery for benign condition, because for instance, you have an enlarged prostate, you cannot urinate very well, you do the surgery for this, like endoscopic or open procedures or robotic procedures, and this can easily end in incontinence if not done properly. But also changes due to radiation. For instance, if you use external beam radiation or things like this, you can actually basically cook the tissue, and this loses the ability to contract, so the muscle is not able to squeeze anymore and keep the urine inside the bladder. Trauma is also another possible reason. And as you can see here, urinary incontinence can have a significant negative impact on the quality of life of our patient. Just imagine living with this stigma, just the idea of having somebody perceiving the smell of urine because you cannot contain it can be devastating for anybody. And the good news is that we have solutions for this. You don't have to live with this. We have many options that can restore your continence. I mentioned briefly before that radical removal of the prostate for cancer is a common reason for damaging the sphincter. Sometimes it's because of the healing process after the surgery. Sometimes it's because of the disease. If the cancer spreads into these organs, so the sphincter, the bladder, or the urethra, this can be, they need to be removed, this portion, and this will affect the continence mechanism. Now, the majority of our patients regain a pretty satisfactory continence within the first year after the surgery, but there are still up to 16% of patients that they require some help. Usually, behavioral modification, physical therapy helps us in regain sooner the continence, the control over your continence. But after 6 months, if the patient have severe incontinence, there's some little chance that this is going to improve significantly just doing physical therapy. So those are patients that we can more aggressively do other things rather than non-invasive options. And there are many options, as I said at the very beginning. We can start with behavioral modifications, like managing the fluid intake, reducing the fluid intake, do the time voiding, means that you encourage the patient to urinate on a time base rather than waiting for the bladder when it's telling you that it's time to urinate. So we avoid this over distension of the bladder, and with the bladder being less full, you have less chance to leak urine. You have interventions, and we do start with this quite soon after the surgery, like in encouraging patients to do physical therapy. We teach them how to do Kegel exercises. There are biofeedback techniques that we can actually, you can relearn how to gain the control over the sphincter. In the meantime, there are some coping mechanisms that we can use to not to be wet all the time. So using pads, diapers, dependents, catheters, condom catheters, or penile clamps. And they all have they all palliation. And as I said before, the intervention like physical therapy, Kegels, and biofeedback are very useful in order to make the patient who is going to be dry at a year to become drier sooner. But if your sphincter is damaged, there is no Kegel exercise. There's nothing to exercise. You should go for something more invasive. The less invasive options are not always the best option. As you can see here, also from an economical standpoint, just using diapers is, beside being environmentally not friendly, it's also extremely pricey. There are patients spending up to $7,000 out of pocket expense just to be able to do some social life without being wet constantly. Penile clamp, for instance, cannot be wear all the time because of the constant compression on a single spot. They need to be moved. They can create some additional issues and problems onto the urethra. And also the condom catheters, because of the sealing that is used, the glue that is used on the catheter can irritate the skin and can actually cannot be used 24/7. So in long-term options, the best solution that we have for our patients is to replace partially or totally the function of the sphincter. We have passive and active devices. An active device is when I need to do something in order to be able to use my system, in this case, the bladder. This is the artificial sphincter. Artificial sphincter, basically, you replace the action of both muscles, the striated and the smooth muscle. And each time that I urinate, I need to squeeze a pump. This is going to deactivate the system. The bladder will empty, and then the pump, the cuff is going to be refilled automatically. The passive device has the advantage that I don't have to do anything. So we place this surgically, and once it's installed, should provide improve the continence. Now, the advantage of this is that, again, it's intuitive, it's a passive. I don't have to do something each time I have to urinate. But the disadvantage is that if the incontinence is severe, this is not going to provide enough dryness compared to the artificial sphincter. Let's have a better look on the Sling. This is the Sling provided by Boston Scientific. It's a trans-obturator sling. The Sling is what the Sling does is that improves the ability of the urethra to have some sort of sealing element. So those are the patients that would respond best to this type of treatments are patients that have the preserved striated muscle. Striated muscle is the one that we can voluntarily contract. Smooth muscle is the one that we have no control of it. It's done innervated by autonomic system, while striated is innervated by somatic nerve system. So what is how can we differentiate patients that are good candidates for a sling? Those are patients that have some good baseline continence. The continence usually is better during the morning and then gets worse during the evening hours. This is because of the fatigue of the muscle. Those are the patients where this smooth muscle is not working. There is no coaptation of the urethra, so they are all relying on having the striated muscle, which needs to be contracted. Patients can easily interrupt the stream of the urine, and those are patients that they usually leak less than 500 milligrams of urine in 24-hour pad weight test. This is where we are measuring how much, what is the increase in the pad weight during the day because of the urine leak. So if you have an incontinence that is more severe than this, that you cannot interrupt the stream, means that your striated muscle is also not working. Those are patients that are going to require something more. And this something more is provided by basically replacing the function of the sphincter. That's why it's called artificial urinary sphincter. It has 3 components: a pump that is placed in the sac. This gains the access to the system. You can activate, you can open and close, or deactivate the whole system. Again, remember, this is an active device. Each time I'm going to urinate, I need to do something to be able to, the system to open so that the bladder can empty. And then automatically it's going to be reclosing. There is a cuff that is placed around the urethra, which substitutes the function of both sphincters. And there is a pressure regulating device, which is placed into the belly, into the abdominal cavity, so that when there is a need for a sudden increase of a pressure, this is going to create this extra boost in pressure. So this is going to close a little bit more the cuff, and it's going to guarantee a better continence in our patients. This is a short video on how the artificial sphincter is working. As you can see here, the same drawing as Dr. Raheem presented before. It's the location of the pump is the same as for the IPPs, for the penile implants. The thing is that here, instead of activating something, we deactivate the cuff. So we squeeze the pump, the cuff opens, the bladder empties, and after a couple of minutes, the pump then the cuff gets refilled with the fluid, and the flow is stopped. If the patient needs longer time, the bladder needs longer time to get empty, you can actually deactivate it, squeeze the pump twice. As I said before, this goes in the same spot as the other pump. Often Dr. Raheem and I are doing combined surgery where we offer to the patients the replacement of both systems that aren't working. So both an implant for the erections and an implant for the incontinence. And in this case, we're going to have one per sac. You're going to have one sac is going to have the pump for the IPP, the other one for the for the sphincter. And the results with this are really, really good. They have quite some patients that have both implants, and they are very pleased with the result. So we can, you don't have to live with the stigma of it's not normal to be incontinent or to be impotent only because you are aging. There are things that we can do. This is part of the healthy aging. That's part of the men's health. And that's why we are, Dr. Raheem and I are very eager in educate and treat patients so that you can have a better quality of life regardless of your age. So speak with us, talk with your urologist. If their cases are more complicated, we are a tertiary referral center. So we are dealing with all the problems that can be generated or the more complicated cases because of the volume that we have. So we have quite some expertise in dealing with from easy to complicated cases. Share your daily pad usage, reduce the pad usage. Don't be ashamed of these conditions. There are a lot of patients that are in the same conditions as you are, and we help a lot of them. So for more information, you can click on the link. You can actually download this link, fixincontinence.com, and you will have all the information that are required. Again, there are some disadvantages, as with any surgery. Sling can have some side effects. There can be like a device failure. Again, as I mentioned before, if the incontinence is severe, it's really difficult to obtain a dryness with the sling. However, you can improve quite significantly the continence rate. Rarely the patients go in retention with the sling. Some patients that develop pain, you may have some irritation at the wound site or foreign body response, but those are pretty minimal and well recognizable and manageable. Regarding the complications of an artificial urinary sphincter, you may have a device malfunctioning. This is a little bit more frequent compared to the one for the sling because the device is more complicated. But usually there are patients with 10 and plus years with the device that where the device function perfectly and doesn't require any additional treatment. Keep in mind that if the device is not working, we can replace part or completely the device and restore the function. Some of the problems are more complicated, like erosion of the urethra. If the patient has a challenging urethra,